And now we will move to the love, parents' involvement in pain relief. And most welcome to Mats Erikssson, who is a professor in nursing science at Örebro University. And you have been involved in research in small and older children for a very long time, in the early 90s, I think. And you have also international collaborations in many places in the world. So we are very honored that you are here, and welcome.
Thank you. Thank you very much. So again, it's me between you and the lunch, but I will try to give you some love at least and some talk about the role of parents in pain management. And thank you for having me here as a speaker. I'm very honored by this, and it's difficult to come after all this, but I will try to give my perspective of what I've been doing. I have this title for the speech, Parents as Partners in Pain Management, but an alternative title actually could be Redefining PCA, which is a Patient Controlled Analgesia, to Parent Controlled Analgesia, which I think is what we should really work with. Who am I then? Elizabeth told you a bit about me, and you don't need to read all this, but as you heard, I've been working in neonatal care since 1983, I think, so I've seen a lot of things happen. I started long before NIDCAP, long before we did any good pain alleviation, and I think that the most horrible thing I did when I was a young nurse at the NICU was to take the metabolic screening blood sampling, because I was sweaty, the kids were screaming, the parents were almost fainting, and that was a terrible situation for just a minor procedure, as you said. Done a lot of work about this, and I think we're much better now. And this is a picture of me before we had parents at the unit, and as a nurse you had to sit with the babies instead, which was nice, of course, but not the way you should do it. But I think the real disclaimer, actually, why I'm doing this is this sign that every second year in Canada there is a conference about pediatric pain. And when you drive into the area by the ocean, there is a lot of bunnies running around in the area. So we see this sign, caution, children and bunnies are everywhere. And I think this stands for what we are all doing. We're taking care of the small and vulnerable ones. We should be careful. We should be advocating and try to protect the bunnies and the children. So what's the problem then? Yes, we're dealing with a lot of children that needs hospital care in the beginning of their life. Around between 5 and 18% of all births are born preterm, and a lot of this is increasing, and also a lot of full-term infants need and receive neonatal care. So we're dealing with a lot of children globally that we need to protect, to be careful with. And almost all these newborn infants, they have some kind of painful treatment. Also the full-term well-being babies, they have vitamin K, they have immunizations, they have metabolic screening tests and so on. But the more sick or the more preterm you are, the more painful events you have. And a lot of studies show that there are around between 15 and 20 per day for the small and vulnerable ones. And as we know, we are very bad at treating this, and we cause problem with them. And what we know very much now is that pain affects the brain. This is a movie that I think should all look on the YouTube from Bonnie Stevens group in Toronto, showing how the pain signals from, in this case, heel lancing, goes through the spinal cord up to the brain and affects it a lot. And it is very illustrative. I think you can have the slides afterwards and you can see the link, because I recommend you to watch that one. And Elizabeth already showed this picture, which I think is very good, summarizing all the evidence that is around immediate and late effects on the neonatal brain from repetitive pain during neonatal care. So I will not go into these details. So what do we know then? There has been a lot of studies over the year about parents in pain management in the NICU. Already Linda Frank from 2004 asked parents about how do you experience pain, and the parents said, okay, we see that there were more pain than we thought that they would have when they were being cared for at the NICU. And they also saw that skin puncture were the most common source of pain, and they were also concerned about the negative effects of pain. Later on, 10 years later, she asked them again, how do you want to be involved in pain management? And they said, we want more information about all aspects of pain. Another study from Great Britain from 2017, there the parents, they thought that the nurses, the health staff, they were quite good to tell if the baby was in comfort or not, but only 40%. The rest did not trust the staff enough. We also learned in a study from Denise Harrison that parents, they want to be partners with the healthcare professionals to use pain reduction strategies and to comfort their babies during the painful procedures. We know that they want enough information, and if they have that, they will also be more involved in the handling of the painful procedures, in the management of that. And the last study is from Australia, I think, and there's from a surgical neonatal ward. The majority of the parents reported that they used physical and comforting touch and skin-to-skin methods nearly always or always, which is you can see over the years this is getting better and better at least. So what can the parents do then? Of course they can and they should be present. They should be the ones that are advocating for their infant, inform the staff, I think my baby's in pain now, I think we need to do something, I can help. And they can also be the ones that provide pain alleviation. And we have heard about this, they can use with holding, facilitated tucking, breastfeeding and skin-to-skin contact is very effective for procedure for minor and moderate procedural pain. New studies about singing to the infant and combining this could be, and they could also of course be the ones that provide sweet solutions and non-nutritive sucking. In many situations you should have the parent standing by the baby when you're doing something or holding the baby, being the one that gives the sucrose if you need that or glucose, being the one that provides a finger or the pacifier to suck on. My group did a scoping review some years ago looking on what was published, and you can see most of the published is about skin and skin contact, also breastfeeding, breast milk, combining different methods, holding and swaddling, massage, facilitated tucking, but not yet so much about infant-directed singing. So how are we doing this in the world? We heard about the ESPR neonatal pain SIG group. Together with them, my research group did a global survey about parents and pain management. So we had answers from 303 units in 44 different countries. There were most answers from high income or high social demographic index countries, but also from some developing countries. And from all these answers, 11% said we have no guidelines about pain at all. But the rest, we asked them, if you have guidelines, are parents mentioning those? And then you can see that 40% did not mention parents, 27% mentioned them as an option in pain management, and 33% recommended parents to be part of the pain management. And we asked them, do parents actually provide pain relief in your units? 2% said never, 4% very seldom, 29% on occasion, 51%, which is quite good, and at least on a regular basis, and 14% always. So I think we are getting better and better, but still we have these 2 and 4 and 29 that not does it so much. We also asked about the attitudes from the staff to have parents participate in pain management. And you can see this vertical line, to the left you have the negatives, and to right positive, going from very negative to very positive. And you can see actually that most of both nurses, nurse assistant and physicians were quite positive to involving parents. So that also gives hope for the future, I think. So again, what can we do and how should we do it? Elizabeth showed also this slide, which we think is an important way of looking at it, that you, in the base, you always have the planning. Do we need to take this test? Do we need to do this procedure? What are the previous experiences of parents, etc., of the infants? Do we have resources enough to handle this situation? Then we should prepare it, prepare the infant, prepare the situation, dry diaper, calm environment, have parents there, give sweet solutions, and maybe EMLA cream if necessary. Then comes distraction and communication, really being present with the child. And then if you do all this and it doesn't help, then you need also to give drugs. But if you do this in a proper way, often you can also avoid drugs. But if you need it, you should give it. And on the right hand, you see that you need to also to do pain assessment, of course, to realize if this works. And how about parents then? Yes, they can be part of this almost all stages. They will not be the ones who ordinate drugs, but they should and be part of all the other parts, also the pain assessment actually. We are doing a study now called the Sweep-Up Study, Parents as Pain Management in Swedish Neonatal Care. It's published the first study protocol, and we are now analyzing the data. And after lunch, I think Martina will talk a bit about the findings. And we did this in two phases. The first phase was a participatory action research where the parents and nurses and staff were interviewed and observed. And they learned about different ways of providing pain relief. And then they did blood sampling, and they were filmed and they were observed. And some of the findings is that you need enough time. You need to prepare to be able to do this. If you're seeing for the child, it helps the parent to focus on the infant instead of the procedure. If you do this in a calm, you will have a calm and trusting atmosphere, both for the parents but also for the nurses. And it was quite feasible to do this. It didn't take much extra resources. Then the second part of the Sweep-Up study is a randomized controlled trials with 225 parent and infant diets, where we did the standard venipuncture for metabolic screening. Children were 3 to 4 days old. They were full term and healthy. And we had 3 arms in the study. One was standard, that is lying in the cot or on the table with receiving glucose. Group 2 was skin-to-skin contact, and Group 3 was skin-to-skin, breastfeeding, and infant-directed singing at the same time by a parent. And we were looking at PIP-R as primary outcome and skin contact and the parent assessment of the situation and of the pain. So we're analyzing these data and hope to be able to publish soon, but we know the parents said it was very meaningful to be part of the pain management. And here comes a little film. Let's see if it starts by itself. Should be without words, just humming or just a very melody that follows the infant. So this is exactly what Piet showed us before. We're creating an environment, a safe and secure environment for the parents and the child, and we do the procedure, and we can do it seamlessly, and the child does not even react. These are some words from another study looking also at parental touch. It's from Rebecca Slater's group in Oxford, where the parents expressed that being part of the pain management was making them calm, they were empowered, they were reassured, relaxed. Some also said that they were anxious, helpless, and stressed, but those are much fewer. Instead, they raised these words saying this was a good situation for us. So parents are really important. There are some studies going on trying to increase technology instead. They call it a camera, a robot for pain relief. And I can understand that you need this in situations where the parents cannot be at the unit. But we must always strive to have the parents with the child. So the role of parents in pain management, this is a study from Linda Frank again. And we saw it in another way before. From not doing anything, to be informed, to be present, to provide comfort, to actually be the informant for NICU staff, to be the decision maker and to advocate for your infant. And of course you want to be as far up to the right as possible on this ladder. This is a study that we did looking at what do the nurses say about parents' role in pain management, and we found 3 different groups, from nurses being in control, where they should be the advocate, they're protecting the infant, from sharing some control to having collaboration. And when we looked at the different countries, we could see that by this time at least, the US and Finland, where we did the study, they were more to the left, whereas Sweden had come at that time a bit further to the right. I hope this is getting better in all countries now. Here's a Dutch study showing some contextual factors that will influence parent involvement in pain management. Important with know-how and communication skills, that the professionals will have practice, that the parent will be involved with a collaborative approach and so on. We will talk with parents with pain. I also recommend this paper to read this because it gives a lot of information how you can work. And the Finnish study showing that factors that promote parental participation is counseling by the staff, awareness of their own role, motivation, family-friend facilities, which is very important, and good communication. Whereas hindering factors are a restrictive environment, lack of knowledge, requirements of everyday life, underestimation of the capacity of the parents, the nature of the medical procedures, etc. And while I was preparing these slides, yesterday actually came the new early view of new papers in Acta Paediatric, and I thought the 2 first papers were Readers Forum, but they had so interesting titles and very important titles, saying that parents are parenting and not visiting. That's one thing. And the devil is in the detail, using empowering language for parents in neonatal intensive care units. These are things that we need to learn. We should also work with parent organizations. We have in Europe the EFCNI, which have standards for neonatal care. There is not so much about pain, but there is something in the care procedures chapter. There are other examples from all around the world where we as health care professionals can work with parents' organizations to make them also demand a better pain care for their infants. So as my last slide, what do we need? We need to be able to have parents involved in pain management. We need legislation and social benefits that makes them being at the unit and taking care. We need the facilities that they can be there. We need them to be willing, and we need the parents to allow them to take part. Thank you very much.
Thank you very much, Mats, for a very, very interesting talk about parent and love. Do we have any questions? I have a question for you. I'm very curious about the venipuncture for the metabolic screening. What is the standard procedure nowadays?
I would say in Sweden it's absolutely venipuncture. We gave away heel prick a long time ago.
Yeah.
Which is interesting because when I talk to my colleagues in Canada or US and so on, we're talking about they're always doing heel prick, and they cannot understand how you could move.
No.
And that was a study by Björn Larsson a long time ago that showed that if you change to venipuncture, you will decrease the pain.
But in your study, you have 3 legs, and you have the standard procedure. What is the standard procedure nowadays?
Standard procedure, it differs, and I think that most units are going towards being held and being skin to skin. But this was done at the maternal units where they had not started doing that yet. So their standard was laying on the table and doing venipuncture.
And the parents outside maybe, not
no,
fainting?
Maybe beside, but not taking part.
Yeah, oh, thank you.
Great presentation. Is the professional also singing?
They could do that, of course.
Wouldn't that be a great idea to harmonize
Yes.
the whole system?
Yes, and we learned that actually during the study that some of the nurses said, "Oh, I used to sing for the infants."
Yeah.
Especially the night nurses when the parents were not there,
Yeah.
because they were a bit.
Yeah. Yesterday we had a mother talking about medical procedures in her child, and she showed a great slide that she as a mother and the child are suffering of uncertainty, dealing with a procedure, but actually what she observed, the staff is also facing uncertainty. Is it going to be successful? You enter a vulnerable setting, you want to be successful immediately. So maybe they could co-regulate each other by making it one.
Yeah, I think that's great.
Yeah.
Actually, I've been working practically with data collection in this study, and these situations, they were so touching. We have mothers sing, but also fathers, and they said, "Oh, I cannot sing. I hope I don't get into the singing group." Then, and then they sat down. They said we helped them starting singing, and they sat for 10 minutes singing skin to skin, and then they forget everything. They sort of relaxed. They felt down, and we did the blood sampling with no reaction from either the parent or the child. So it's a fantastic situation.
Mats, thank you for a very beautiful talk. I just wanted to see if there are some studies on this parental involvement and empowerment, because there are, I mentioned this yesterday, I'm collaborating with, there are 6 hospitals in India and 3 outside of India. They're all part of the same network, doing congenital heart surgeries. Many of those children with congenital heart disease are infants. And 80 to 90% of the ICU care is being provided by the parents. And I don't know if they call this program is called Matra Chaya, which means within the shadow of the mother. So I don't know if there's some way to perhaps involve or do some studies on this phenomenon, where like children come from the operating room, open heart surgery, and they go directly into the mother's lap instead of on the ICU bed. And then the mother does the suctioning or whatever, wound care or things like that. So I don't know if it would be possible for you to study this phenomenon.
It sounds very interesting and a great way of doing it. That's the way it should be done. Maybe we blame poor resources for involving parents. We say they do it in developing countries there the parents have to be there because we don't have resources. Maybe it's the best way of doing it. Yeah, let's talk about it.
Hi, thank you, Mats. In Sweden, we have a lot of discussions when we talk about parental participation in all procedures and in everything in the care of the baby. We have a lot of discussions of how pity we feel for the parent, about the parent has to sleep, has to eat, all these practical issues that we prioritize to decide for the parent that they should go to another room and sleep instead of being with their baby. What is your recommendation on how we move on from this way of thinking and instead to this way of thinking in these examples in India, where the parent is really, as it sounds, totally stuck to the baby?
Yeah, we as staff, we must learn and understand that the child belongs to the family. We are there to help with what they cannot do, but the child is theirs. We wouldn't go into a home and say, "Oh, we need to take your baby for a while because we think you need to sleep." That doesn't happen, but in hospital it happens. So it's we that need to relearn.
Thank you very much, Mats. Another round of applause. To sum up, what I, as a manager, take with me from this session is that we should educate our employees in playing, and we should educate our employees in singing. So, thank you very much.